Good afternoon, everybody. I'm Rajat Jain. I'm one of the endourologists or kidney stone specialists here at U of R. And I'll be talking to you today about preventing and treating kidney stones. If you have a burning question, you can interrupt me if you like, but otherwise you can just wait until I'm done with all my spiel here and we can have a question and answer session. Okay? All right. So, thank you for allowing me to present today. This is a really pretty unexpected turnout, so I'm very happy you're all here, and a lot of people joining on Zoom also. So I want to start by talking a little bit about the Kidney Stone Treatment Center here. And it's really not one place or one person or one thing. We have expanded over the last few years, and we are doing procedures and seeing patients all across the Rochester and Greater Rochester and beyond region. We have kidney stone treatment going on at Strong, Highland, Canandaigua, Brockport, Batavia, Dansville, Hornell, and Geneva. And not only that, we're treating the kidney stones, but we're also trying to prevent kidney stones by having deep collaborations with our registered dietitians and nephrologists to handle the medical and dietary sides, which the urologists don't do as much, but we certainly do. And I'll be talking some about that today. Well, a lot about that today. One other thing, the Stone Hotline. So the Stone Hotline was primarily created for primary care doctors and ER physicians to be able to reach us quickly to facilitate patients to be able to get in for procedures and to be seen in the office. It morphed a little bit over time where some patients were given that number and they were able to call in. Now, what ends up effectively happening is that kidney stones tend to manifest at 1 a.m. and you have nowhere and nobody to call. And if you do somehow have that hotline number, and it's fine if you do, it's not a secret, it's actually on the website if you look it up, but it directs you to the office answering service. So it'll go to me or one of my partners or one of the residents. There's always somebody available to talk to you about what's going on and troubleshooting. You may know what's going on if you've had one before, but we can help facilitate getting you into the ER or getting you through the night or something like that. And as I said, we've been expanding over the years. If you are an old patient at University of Rochester, you may have known Dr. Urtert. He was here for many, many, many years treating the vast bulk of the kidney stone patients here and did an amazing job building up the treatment center. And as he transitioned out, I came in. And we've grown that team to now include myself, Dr. Corrier, Dr. Tapiero at FF Thompson, and Dr. Sharma at Hornell in the southern tier, who are all endourology fellowship-trained physicians, urologists. So what that means is that they were essentially spent a year or two on top of their basic urology training to delve further into expertise in kidney stone treatment. So we're really pretty well stacked, and we're going to continue to expand in that regard. And Dr. Levy's name there, Dr. Levy is a nephrologist, so the medical side of kidney disease, who is interested in kidney stone prevention, and he works very closely with us for our more complex patients. When we have a lot of those, believe me. Jamie Allen McKeown, she is a nurse practitioner. She has been with our team now for almost 9 years. She knows more about kidney stone treatment and prevention than most of our residents. And sometimes patients feel like they didn't get to see the doctor, but frankly, if you're seeing Jamie, then you're seeing essentially a doctor. Erin Ruggieri also joined our team a couple of years ago. She's learned really fast, and I'm very, very comfortable having patients see her in my stead or in anybody's stead to make a diagnosis, to continue treatment, or make a plan. So we are really doing quite well in that regard. This is the number for appointments, for after hours, for basically all contact for our office. Now, our administrative team has made really great strides in the recent months and over the last year or so in really facilitating patients to be able to access us during work hours. It used to be that it was very difficult to talk to somebody who doesn't know anything about medicine and have them relay a message to somebody else who then will come back to you maybe the same day, maybe not the same day, and then eventually that message would reach a nurse practitioner or a doctor maybe the next day. And that's really changed. Now, if you call the office number today, there should be an option, correct me if I'm wrong, Mark, but an option to reach somebody today. There's a symptomatic line. And again, so you have that after hours number to reach somebody and troubleshoot, but that should be available during the day as well now, which is a great achievement, I believe. So before we talk about kidney stones, we really have to talk about what the kidneys are, what they do. Okay. So why do even stones get there? So what do the kidneys do? If you ignore the complicated diagram for a second, really what the kidneys are doing is that they are two organs. They sit in the back of the body, just under the rib cage here, and they're constantly processing and filtering the blood. They do this over and over again throughout the day, and they do it so many times that they're doing about 200 to 300 liters of processing of blood in a single day. And mainly what they're doing is filtering waste and toxin out of the blood and dumping it into the urine. But they're also regulating the levels of a massive number of chemicals and molecules in the blood, either increasing them if they're too low or decreasing them if they're too high. And we'll talk about some of those chemicals as we get into that, because some of those are things that you might recognize, like calcium and oxalate and citrate and phosphate and uric acid and sodium and all these kind of things that are very important for kidney stones. So once the waste has been removed, so actually let me back up. So this is the overall kidney, right? That's where the kidney bean gets its name from. The blood is going into the kidney here in this red. That's the unfiltered blood. It goes all the way around, and it's going to go into this sort of the meat of the kidney here, where if you kind of zoom in with a microscope, you're going to get into this kind of structure, which is called a nephron. And there are millions and millions of these in the kidney, but basically all of the work of the kidney is done in the nephron. So the unfiltered blood comes in, all the exchanges of the fluids and the waste happen in this tube, and then the clean filtered blood goes back, and all the waste comes down into this collecting duct, and all the collecting ducts basically then empty into these areas, which are called the calyces. And the calyces collect into this thing which is called the renal pelvis, and the renal pelvis empties into the ureter, and that goes all the way to the bladder. Okay, so that's the ultimate goal, right? To remove the waste from the kidney, from the body via the urine. So how do kidney stones form? So as I said before, the nephrons are where the blood is filtered, Actually, what I'm going to do is I'm going to go to the next slide, and if you look at this other, much more amateur picture of what a nephron looks like, so there's the unfiltered blood coming in and the filtered blood going out, and this yellow is this tubule, the nephron. And there are areas here where, because of the way in kidney stone formers, the problems that they have cause these plaques of calcium oxalate or calcium phosphate to build up in between the space between the nephron tube and the blood. So this in-between space is called the interstitium, and this is where all the problems start. So once you have a plaque that's built up here, that plaque really can't go anywhere. It can't dissolve, it can't move anywhere. All it can do is grow over time. You can prevent that growth by some of the things we're going to talk about, but usually it just grows. Eventually, it grows to the point where it breaks through the surface of the calyx right here. And so if you were to put a camera in here, like we do, on a daily basis, you would actually see where that surface is broken by the plaque. So now when this plaque has broken the surface, this plaque is now in contact with the urine. And all of that waste product that was dumped in there by the processes of the nephron. When all of those waste products come in contact with this plaque, that's how you get the crystal forming, and the crystal aggregates and it becomes bigger and bigger until it becomes a visible stone, and then eventually it pops off the wall, and that's when the mayhem starts. So you have a couple of different ways that issue can happen. So you have this plaque, and then you have another thing which is called a Bellini's duct plug, which is essentially this entire duct being blocked by a plug of stone. So if you look at, if we go back, I changed the order of my slides. Okay. So basically, stones are forming on top of these things called Randall's plaques or Bellini's duct plugs, where they come in contact with the urine. Okay. So that's how stones form. So what actually are kidney stones, right? So what kidney stones are essentially composites of crystals and proteins. So they're not purely crystals. They definitely have a big biologic component to them in that. And so we cannot treat them as a stone that's found in nature. Like it's not a limestone or something like that. There's a biologic component to it, and that becomes important because some types of kidney stones do not respond to the same things. So they all really need individual attention, and we'll get into how that individual attention is applied. So calcium crystallizes most commonly with something called oxalate, and that causes calcium oxalate stones, and also less commonly with something called phosphate, and then you get calcium phosphate stones. And then you have a whole bunch of different diseases and medications which can increase your risk of kidney stones. There's entire textbooks written on this, and obviously we're not going to cover all of that today, but there are things like genetic diseases like cystinuria, and even more common things like diabetes, which increase your risk of kidney stones. So this is a picture of what when you put a camera all the way into the calyx, this is what a Bellini's duct plug looks like. So you can literally see that the opening, which is behind here, is completely plugged up with this piece of stone. And here is what that Randall's plaque looks like when it's broken through the surface. So this is normal kidney tissue here, and this is the Randall's plaque, all this white stuff. And eventually this is going to break through enough that you'll get crystals forming on top of this. And then when you look at the other side of this stone, once you pluck it out, you can actually see this little tubular thing, which is the actual plug itself on which the stone formed, if that makes sense. And here are some other gross pictures of kidney stones. There's small ones here on Bellini's duct plugs. Here's some, and they also form crypts within the calyx itself. And so what you can sometimes get, and some of you may have heard this during a consultation, is that you have buried stones or stones in the meat of the kidney or intraparenchymal stones. And so sometimes what you see is that you go in and you can see that there's a stone under the surface of the tissue here. And this may not ever move. It may not come out of that, but we can laser and get it out. But if we left it alone, it may not ever do anything. And so you can see it on the CAT scan. It is a stone, but it's not a stone that's going to cause your problems. So sometimes an ultrasound will trick you into thinking you've got 11 stones, but really you don't have stones that can cause your problems. So, okay, so why would we ever bother treating these things? Obviously, everybody knows, when you have an acute kidney stone attack, a stone has gone down into the tube, into the ureters, blocked the kidney. It stretches the kidney behind it, and the stretch causes inflammation, and that causes, it's basically, we feel it as pain. We perceive it as pain, right? And so why would we bother treating them? Well, one, the pain, right, to improve the pain in the acute. And then the second thing is really recurrence. We don't want kidney stones that are sitting in the kidney to cause a problem later on. So, and, and the other reason why you want to treat and prevent kidney stones is because if you compare, and there are many, many studies on this, but if you compare people who are non-kidney stone formers to kidney stone formers have significantly worse health outcomes than non-kidney stone formers. So if you look at this graph here, this is referred to as the Olmsted study. This was a very long observational study out of Mayo Clinic in Minnesota. And basically and you know, if any of you have ever been to Rochester, Minnesota, there's nothing else there. Basically there's the farms, and then there's the Mayo Clinic, and really nothing else. So everybody goes to Mayo for all of their care, and so they have very, very long-standing medical records where they know everything about the patients for, you know, decades and decades. And so what that allows them to do is actually do some really great research where they show the cumulative incidence of health outcomes between non-kidney stone formers and kidney stone formers. So what's worse in kidney stone formers? The incidence of high blood pressure, chronic kidney disease, the risk of dialysis, the risk of stroke, the risk of heart attack, reduced bone mineral density leading to increased fractures over and above the baseline expected for the population. So all of these things are worse in kidney stone formers. So really, if you've ever had a kidney stone, you don't want to become and stay a kidney stone former. You want to improve that so that you don't get kidney stones anymore, because the health outcomes are going to be worse. Yes, sir. Oh, did you have a question?
Incidence of what? Kidney stones or all those other health?
Of all of these things. So here, the black line is stone formers. So you see that by 15 years out, the stone formers are having a lot more of these things.
I thought they were having one more stone in 2 decades. Okay.
Yeah. So, but you know, this is just one particular cohort of patients, right? This has been replicated in other patient populations throughout the world. So this is not just something unique to Rochester, Minnesota. So the bottom line is, if you have pain, we should remove the stones that are causing the pain. And then we should do careful, repeated evaluation for prevention of future kidney stones. Okay, so what do we do in the acute phase? So, you know, if you have pain and it's bad enough, you may be starting to throw up, you may start to have fevers, you may have blood in the urine, you're going to end up in the ER, and then we usually will end up doing some sort of imaging, sometimes an ultrasound, often a CAT scan, CT scan, and that's going to show you where the stone is, where it's causing pain. And these are the 3 most common areas. So out of the renal pelvis into the ureter, there is the ureteropelvic junction, or the UPJ. That's one of the most common regions. And then another most common region is the ureterovesical junction, the vesica being the Latin name for the bladder. So that right as it's coming into the bladder, and the third most common region is that there is a big blood vessel which the ureter crosses right over, and the stones tend to get stuck there. So 3 common places. So in the acute phase, so once a patient is in the ER, the vast majority of kidney stones are going to be less than 5 millimeters, which means that statistically a patient will have something like a 90% chance of passing it. Now for the individual, it's either you pass it or you don't, but statistically you have a very good chance. So often, if pain can get under control in the ER, they'll get sent home with what's called medical expulsive treatment. That basically means they're told to hydrate, they're given pain meds. Sometimes in the US, well, this is a whole another discussion, but in the US, the first type of pain med has traditionally been opioids, but the data really suggests that NSAIDs, or non-steroidal anti-inflammatories like ibuprofen and a whole bunch of other ones, actually work better for this particular situation than opioids. So that's changing now in the US, especially with everything that's going on with the opioid epidemic. So pain meds, pain control, fluids, and then there's a medication called tamsulosin, which relaxes the muscles of the ureter and increases your chances of passing the stone by a few percent. It's a pretty well-tolerated medication, so it's sort of a, well, you may as well do it. And then if you can't do any of that, or if you have some other issues going on, like concurrent infection or vomiting, or your kidney function has decreased acutely, then you may need some surgical treatment, whether that means putting in a stent to essentially bypass the stone and relieve the obstruction, or to treat the stone right away. And there's a lot of factors that go into it, but that's basically what we can do. So let's talk about the three main types of treatment that we would do for a kidney stone. So shockwave lithotripsy, this has been around for many, many years. It was developed in the 70s and really came into play as an effective available treatment around 1983, 84. And I think we got it here at U of R, I think 1986. So we still have the original notebooks where we've noted all the procedures we've done. I went back through all these notebooks, and I think at the end of 2022 we had done just under 32,000 procedures in our shockwave lithotripsy unit. So that was pretty cool to look at that. We still have those original 1986 notebooks. Basically what shockwave lithotripsy is, there's an external machine, and you'll see a little video on this, that comes up behind the patient, and it sends out little ultrasound waves. And those are targeted on the stone using an x-ray, and it breaks this. We hit the stone about 2,500 times. It breaks it up into dust and small pieces. You pass the dust, and you just pass it naturally as you would urine, and hopefully nothing gets stuck and cause pain, which it can. But usually if you select the stone well, ideally smaller and softer stones, they will pass, and it's a very nice procedure because the recovery is the easiest of the three that we're going to talk about. But there's no guarantee that fragments will pass, and that can be an issue if stones are not selected well. So let me see, can somebody help me play this video? No, it's I have to, there's a play button on there. So just little schematics here to show what happens. So you have the transducer here, and we lay the patient on the backs to bring it right up to the kidney. Yep. Almost. What if you press spacebar? No. Sorry. Can't see the pointer. What if you right click? Maybe can you press escape and go get out of the slideshow? No? But it doesn't look nice. Okay, well, if you can imagine a very nice video here of ultrasound waves coming up to the stone and it breaking up into small pieces, and then they pass very nicely down the ureter and into the bladder. That's what that would look like. All right, so the second one is called ureteroscopy, and that essentially means we have a scope or a camera that goes up in through the urethra and the bladder into the ureter and into the kidney, and then we physically look at the stone, and then we use a a laser to break up the stone. Sometimes, if it's small enough, we can just grab it with a basket and pull it all the way out. But essentially, this is a non-invasive. Are you doing that? No. A non-invasive way to treat small stones. So if, for example, you had 5 stones in the kidney, Shockwave wouldn't be a good option because you can really only treat 1 or 2 stones with that one. But if you had 5 stones, you could do it with a ureteroscopy, even if they were small stones. But if you can go up to small and medium-sized stones, and now with the laser technologies that we have, and incidentally, this is one of the things that we worked really hard on, is standardizing all our equipment across all our 5 major hospitals in the system, is that we have the same technology and all the same equipment available to all our providers, so you get the same care anywhere you go. You can treat these stones without any incisions, and then at the end of the procedure you have a temporary stent. Now, the stent really is the worst part about this procedure because it causes most of the issues that come up after in the post-op recovery, and you don't have that with the Shockwave. And so if you can get a Shockwave, if you can be seen by somebody who can do a Shockwave because they have the lithotripter, then that really is in your favor as a patient. But Shockwave lithotripters are expensive to buy and to maintain. We're lucky enough to have one, and we are lucky enough to have an institution that believes that we should have the ability to provide that as an option. So that's good. You want to try again with the video, or? Well, I'll keep going while we're trying maybe. So, oh, can you maybe go to the next slide? Because this is just a schematic. And yeah, so this one works. Basically, these are views of ureteroscopies done with various different types of ureteroscopes. So what you're seeing on the left, that gray wire that you see, that's the thing that we use to actually access the kidney in the first place. And that's called a safety wire. And we go alongside that, and so we can see the stones, and you can see how some of them are smaller, some of them are bigger. The smaller ones we can actually grab with a basket and pull all the way out. If you look at the middle one, you can see this is, we actually had a pretty large stone, so this was about a 25 millimeter stone. For various reasons, we couldn't do the third option for treatment that I'm going to talk about in a second. So we had to do ureteroscopy, and we used a laser, and we, over the course of about an hour and a half, we just kept breaking it up, and now what you see here are fragments which are approximately 1 millimeter or smaller. And now the patient's going to pass all of these, and this particular patient did very well in terms of passing them all. And on the right side, you can see that that's that laser fiber we talked about. The size of that laser fiber is 0.2 millimeters, so it's very small. And it's, you can see that the chunks that are coming off the stone are really minuscule. They are essentially dust. And that's the benefit of the newest laser technologies that we have, is that we can really turn these big stones just right into dust. So, so at least that video works. So that one was a good one. Okay, so third option is a percutaneous nephrolithotomy, or PCNL for short. And this one is really used for larger stones. So under certain circumstances, you might have a stone or a patient that makes stones because of infections, and that becomes a cycle where you get infections and the stones cause a recurrent infection situation. And so when you go in to remove stones, you really need to make sure you removed all of the stone and the dust. You can't really leave anything behind. And when you have a ureteroscopy, like you saw, it's just a big pile of dust. We're just hoping that the patient passes that. But that's not a 100% guarantee. So when you want the 100% guarantee, you might want to do a percutaneous nephrolithotomy. And especially when you have large stones, like we did a procedure a couple of months ago where the patient had about 5 centimeters worth of stone. So that was like probably about that big, whatever that size is, about the size of a plum worth of stone that we removed out of a patient. And you can't really do that by turning it into dust. It would take, 8-9 hours worth of dusting. So what this procedure is basically you come in for an overnight stay, we make a little incision in your back, so it's still a very small incision, and we have a needle that's inserted right into the kidney directly through the back. We use an x-ray to guide that needle, and then once we get it into the kidney, we make that tract wider, we put a tube in there, and then through that tube we have an instrument that goes in and it breaks up the stone into dust using ultrasound waves, but then it also sucks up the dust at the same time. So that's the benefit of being able to remove large amounts of stone through that particular instrument, which is called an ultrasonic lithotripter. Now, obviously, this is an invasive procedure, so it is more prone to complications or injuries. However, they're really pretty darn rare. Yes?
Excuse me. For the urologoscopy,
Mm-hmm.
Because when they did my cataracts, they had a vacuum to remove debris.
Uh-huh.
So why isn't a vacuum used
Yeah, great question.
for the little particles?
Yeah, there are some of those things that are in development. They work so-so, but in fact, we just ordered one to try. So yeah, it exists. Very good question, though. All right, do we want to try a third video? Hey, okay. So here what you can see is this is the needle. This is an x-ray machine, and you can see the x-ray image here. And, well, it skipped here, but he actually has a camera inside the kidney, and here you see that needle as he's pushing it in. It's actually coming right in there. So you see the needle coming in, and this is actually how I do the procedure too. So once that needle is in, you get the urine coming back, you put the wire in through the back, and then over that wire, you're going to put in the tube that goes directly into the kidney. And oh, did it just stop? I think there was more to that one. But in any case, it's that's, you can go in then and then just break up that stone into dust and suck it all out. So good. So that's the acute phase. That's the fun part for me. That's what I signed up for initially. But there's a whole another side to this, right? So, and this is really most of where the patient's interaction with kidney stone comes in is the chronic phase. This is how we prevent recurrence. So where does that start? So first thing is, were we able to get a piece of the stone for analysis? And that's called a composition analysis. And essentially that's going to tell us, okay, was the stone 100% calcium oxalate? There's two types of calcium oxalate. What were the percentages? Was there any calcium phosphate in there? Was there uric acid in there? So it tells us all of that stuff. So that's where we start the preventing of the recurrence. And then the second thing we do is a 24-hour urinalysis, which some of you may be familiar with. And based on and I'll talk about that more in a second, the 24-hour urinalysis really tells us what can we do to prevent kidney stones in the future. So that could be behavioral changes like fluids, it could be diet, it could be medications, it could be a combination of the three. And then it really requires regular follow-up. So it could be repeating the urinalysis to make sure we're going in the right direction. It could be repeating imaging. It could be both of those things. So, all right, so this is what a 24-hour urinalysis looks like. It may be familiar to some of you. But this is done through a company called Litholink, which was started by by Dr. Fred Coe, who is really a luminary in our field. You'll see his name come up a couple of times. And if you are interested in really learning about kidney stones and kidney stone formation, his website at University of Chicago is it's really pretty amazing amount of knowledge in there. But basically what this tells us, and they've put nice colors in here to really make it obvious, is that there are certain risk factors, And we measure these in this 24-hour urine. So you get, a jug sent to your house, you collect your urine for 24 hours, you send it back to the company by mail. They run a whole bunch of different tests on it, which you see here. So all of these things are the tests that they run on there. And they give you the numbers, and then they basically put them on a continuum where red and more bold and bigger, it means worse. So they give you this one, but this is really the one we look at because we need all of the information. So if I zoom in there a little bit, I'm going to show you for this sample patient, you see that this person has had 3 different urinalyses done, litholinks done. And so we can see over time that this patient, when they started out, had a urine volume that was 1.32, and they increased it a little bit, and then their doctor beat them up a little bit more, and then they increased their urine volume. And then, once they got into this green zone, 2.6 liters, then you say, okay, now maintain that for the rest of your life. So that's the first thing we look at is urine volume, because that's far and away the most important risk factor, and we'll get into that more in a second. This is sodium. We look at that a lot because it comes into play because of the way our average diet is in the US. Now these 3 things are calcium, oxalate, and citrate, all of which are very important to us in this analysis, and we always have to look at basically all of these things together. None of them sort of stand in a vacuum. And this is also uric acid, which comes into play with particular types of stone formers. So drinking fluids, right? So drinking fluids is very important. It's the first sort of thing that people hear. When they get a kidney stone, all their friends and family come and tell them, well, you got to drink more fluids, you got to drink more fluids. And that's true. That's true for a reason. It's because kidney stones can be prevented by drinking more water, and there's actually research to prove this, right? So there's actually very few things you'd be surprised to know. We hear these things like randomized controlled trials and medical research. There are a lot of flaws in medical research. So when we really get high quality trials, we really hold on to them. Because there's the few things that we can really tell patients with surety that if you do this, this is going to happen, or this is your chance of this not happening, etc. So we had a trial by somebody called Dr. Borghi, B-O-R-G-H-I, who actually the 2 most important trials in kidney stone prevention were both under his watch. So the first one was from 1996. And basically what that showed was that if you tell patients that you're just going to drink to thirst, and then you compare them to patients who are told you must drink enough fluids to make 2.5 liters of urine a day. The people who made 2.5 liters of urine a day had a 60% fewer stone events over 5 years than the people who drank to thirst. So basically that tells us you'll make less stones if you drink more fluids. And then not only that, but then the patients who were drinking 2.5 liters per day, they took an average of 13 months longer to the next stone event. So you can prevent your stones, and you can also delay your stones by drinking more fluids. So, some of you may have caught on to the fact that the 2.5 liter folks still made stones. So fluids are important, but they're not the be-all, end-all of stone prevention, which is where we get sodium. So sodium is the most important modifiable risk factor in stone formation after fluids. It really should be with an asterisk. And so when you see this quote by Dr. Koh, I really like this because it's a hard concept to explain, because sodium is not directly what causes stones, right? It's calcium and it's oxalate and it's phosphate. But if you look at sort of the physiology of how the body gets rid of sodium, it really plays in very directly. So if you eat too much sodium, the body will use what it needs and it will dump the rest into the kidney to be discarded, the way we talked about through the nephron. 90% of the sodium that is discarded into the urine comes from the diet. So some of it comes from other processes in the kidney, but basically if you're getting sodium in the urine, it's coming because you're eating too much sodium in your diet. And then calcium follows it. So if you have too much sodium in the diet, you have too much calcium, you have too much sodium in the urine, then you have too much calcium in the urine. And now you're at risk for kidney stones. And 90% plus of kidney stones are calcium-based. So there's study after study that shows basically as the urine sodium goes up, the urine calcium goes up with it. So that problem is compounded for a group of people who are called idiopathic calcium stone formers, or to put it even more jargony ways, they have idiopathic hypercalciuria, and I'll talk about what that means in a second. So this is from Dr. Koh's website. So this is basically an amalgamation of a whole bunch of different studies that were done that compared urine sodium and urine calcium in patients. The red ones here are non-stone formers, and the blue ones here are idiopathic hypercalciuria patients. So what that means is that these are patients who have high calcium in the urine, but we don't have a reason why, which is actually the bulk of those patients. And what you see here is that in non-stone formers, as the sodium goes up, the calcium goes up, but it goes up kind of about at this rate. In the idiopathic hypercalciuria patients, as the sodium goes up, the calcium goes way up. It goes up way steeper. And and so that is really a very important finding, is because if you do that 24-hour urine to figure out why you're making stones, and you're found to be this idiopathic hypercalciuria group, then you really need to really stay on top of your kidney stone prevention compared to somebody who has something different. So that's the reason, another reason why you really want to do 24-hour urines. So, and we'll get to some myths of kidney stone prevention in a second, but one of the biggest ones that we run into, and this is not any patient's fault, because this is actually what we used to tell patients was, well, you're making calcium stones, so you should reduce the amount of calcium you ingest. And that really isn't true. It actually has the opposite effect. So if you go on a low calcium diet, you can actually increase your risk of kidney stones. So don't do that. And then that issue is actually even worse in women. So in women, you actually, especially women, should maintain a normal to high calcium intake, and I'll talk about actual numbers for people who are interested in that thing in just a little bit. Doing okay on time, I think. So high calcium intake means you add calcium, you add mineral density to your bones. You can basically offset the losses that you get from that idiopathic hypercalciuria disease. So instead of your bones basically being leached of the calcium that they have, you can add it back by having a low to high normal calcium diet. If you ingest a good amount of calcium, you also decrease the amount of oxalate that's absorbed into the body, which also has a good effect from a kidney stone prevention standpoint. So what that essentially ends up happening is that at a baseline, if you have idiopathic hypercalciuria, you're going to follow the general dietary guidelines that we give to all kidney stone formers, but then you still may need something else. You may need to be on a medication to really get that calcium out of the nephron. Okay, so oxalate. So the most common type of kidney stone is calcium oxalate, and oxalate is in everything. It's in all like plant food, and it's impossible to avoid. And one of the things, again, through no patient's fault, because this is what we tell people, is that they are following low oxalate diets. And the problem is that there's really no great evidence to suggest that following a low oxalate diet will help you prevent kidney stones. Now, there's a big asterisk there because that's not true of everybody. And I actually just saw a patient today whose only problem in that 24-hour urine was high oxalate. And when I talked to him about that, he said, and we talked about where oxalate comes from, he said, oh yeah, I eat peanut butter and peanuts all day, every day, multiple times a day. And I said, okay, well, that's the thing. So for him, low oxalate diet's important, but for most people, it actually doesn't help with kidney stone prevention. And it's one of those big things that people put a lot of energy into, and it doesn't get them anywhere. And then they get frustrated, and then they come to see me. So low calcium diet, like I said, increases your risk of kidney stones. One of the ways it does that is by increasing the amount of oxalate that is absorbed in the body. So here you can see all the different types of things that have oxalate in it. There is a really great website. There's one of Dr. Koh's RNs that used to work with him by the name of Jill Harris. She has a bunch of books and YouTube videos and all kinds of resources and a website, I believe. You can take a course with her. She has a great website, and I have that at the end of the slides, where you can go and look up something and look at its oxalate content. So this is important to know, but as I said, not so important as once we thought it was. So acid, right? This was part of the title of the talk. So what is acid? So in general, there are some foods that have an acid load, that have a higher acid load, and there are some foods that have a lower acid load. So in general, things like meats, animal proteins are going to generate a higher acid load in the body. When there's too much acid in the body, it has to be neutralized by a buffer, right? It has to be buffered by an alkaline substance. Usually that buffer comes out of the kidney. And so then you are left with less citrate in the kidney, and citrate is very important for kidney stone prevention. So if you are generating a lot of acid load through your diet, you can unintentionally increase your risk of kidney stones. So there are some studies that show that if you have a very high animal protein intake, you're going to cause more kidney stones. The data on that is a little bit weak, but if you're going to really you could go the whole distance here, there's a lot of overlap between that high animal protein diet and the high sodium diet, and in general, the diet that makes your kidney stones worse and more recurrent. So potassium intake gives you a net alkali load. So, a higher potassium diet would be a good deal for somebody who has kidney stones. Having said that, not everybody should be on a high potassium diet for other various medical reasons, but that's a discussion that you should have in one of those frequent meetings with your urologist or nephrologist. Probably with your nephrologist. Just kidding. So the kidney stone diet, right? So this is kind of what I was talking about. So in general, if you were to try to avoid kidney stones, knowing nothing else about yourself other than the fact that you've had a kidney stone, you would want to be on a low sodium diet, which in the US we consider really about less than 2,500 milligrams a day. Low oxalate diet, and that's again with the asterisk that, it takes a lot of energy and a lot of thought to try to get your numbers consistently under this, and that it doesn't affect a lot of people. But if you wanted to really avoid, probably just say, okay, well, you're not going to have spinach every single day of your life. You're not going to have peanut butter multiple times a day, and you'll probably be fine. We had one patient who, him and his wife, they would grow rhubarb. So what they would do for about 4 or 5 months of the year is have rhubarb pie, usually once or twice, sometimes 3 times a day. And he was one of the patients whose oxalate levels were, through the roof. And that was the only thing that was wrong on his 24-hour. I said, well, I think we can fix this. But you'll have to do it. So normal to high calcium diet, and what that means in numbers is 1,000 to 1,200 milligrams a day. For reference, about 300 milligrams, if I'm remembering correctly, in an 8-ounce glass of milk. low refined sugar. So there's some data on this, right? So if you have diabetes, you have an increased risk of kidney stones. There are multiple different mechanisms of that. But one of the mechanisms is that basically having excess glucose will cause some downstream changes which give you essentially less of those citrate buffers that you need. So if you are having too much refined sugar in your diet, that's going to give you increased risk of kidney stones. And then normal protein intake. We are really beyond, in the US, there's a lot of media, a lot of stuff about the amount of protein that you need and how you should be on a high protein diet. And the fact of the matter is most people don't need anywhere near the amount of protein that they're ingesting. So if you measure your weight in kilograms to just have a normal amount of functioning, if you are a mostly sedentary adult, is about 0.5 grams per kilogram per day. If you are a very active adult, you can bump that up to 0.8 to 1. Going beyond 1 really should be only for people who are extremely active. That's like 5+ days of heavy exercise per day. Most people aren't doing that, and they really don't need as much protein as they do take in. So those are that's really the kidney stone diet if you were to sum it down into one slide. Some myths. So let's talk about some of the myths. So lemon water will dissolve my stones. This is actually kind of true, which is why there's asterisks there. But it is only true for uric acid stones, and only if you take in a huge amount of lemon, which you won't do it by squeezing, a slice of lemon in your water. That won't work. But you can technically dissolve uric acid stones. It takes a very large amount of potassium citrate, which you have to do with a prescription. So you can't dissolve your stones. 90% of stones are calcium-based. Those will not dissolve with lemon water. Cranberry juice does not prevent stones. Cranberry juice doesn't do a lot of anything, other than provide you volume. So if you do want to drink cranberry juice, that's fine, but it's just you're getting more fluids, and that's good for kidney stones. The myth, I think, here is because people conflate kidney issues with UTIs, and there is some data that shows that if you get concentrated cranberry extract, that can prevent certain types of UTIs, but the juice doesn't do anything for UTIs or for kidney stones, other than the volume, like I said. Soda drinking is causing my kidney stones. Caffeine, coffee, tea is causing my kidney stones. That is not true for the vast majority of patients. There's some interesting exceptions to that. I had a patient who was drinking 3 liters of Coke per day. And so that's enough phosphate to actually cause you to get stones. Tea, there was one person who had about 4 liters of iced tea a day, basically for about 5 months of the year, and she had oxalate stones. Water is the only thing that can prevent stones. So people really kill themselves saying, well, I can't drink anything but water, but I hate water, and so I'm not going to drink anything, and now I'm just going to be mad about getting kidney stones. Actually, it doesn't matter. Most things that we drink are mostly water. So if when I tell patients what they can drink, they say, I don't care what you drink. You can drink whatever you want. Water, tea, juice, milk, wine, beer, whatever you want to drink. The more the better. And that's really all I have. So I want to thank you for your time. We'll open it up for some questions here. These are the 3 websites. If you're interested in learning more about kidney stones, these are the best patient-friendly websites. The last one is the one with Jill Harris, where you can take courses, you can buy books, etc. And she has the oxalate search function there, and that's very helpful for somebody who's looking into oxalate. So again, thank you so much.
Yes, I have a question. I currently have a 7-millimeter stone in my left lower lobe, and it was caught on x-ray in October. And I had another x-ray since, and it hasn't moved. And my urologist said it could be there a couple of days, or it could be there the rest of your life.
Is that a comment or?
No, is this true? I mean,
Yeah, yes, it's true. So the
is
statistics
there side
basically-
effects?
Yeah, the statistics are that if there were 100 people like you, 50 of them would have a stone event, meaning the stone will move in the next 5 years, right? But 50% will not. So out of the 50% that don't have a stone event, they could be sitting with that stone their whole life. But of the 50% that do have an event, it could be 15 years from now, or it could be on your way home, and there's no way to predict.
So basically, if I never had the x-ray from my back, I never would have found it.
Unless it moved.
Okay, thank you.
Yes, ma'am.
Yeah.
Oh, we have a question here.
I have an oxalate issue with stones. Do you create both, oxalate and phosphate kidney stones, or?
In general, can you get both?
Both.
Yeah.
Oh, okay.
Yeah, you can get a mixture. So we have patients that, have 60% calcium oxalate, 40% calcium phosphate, and all variations, yeah.
Okay, because I'm not feeling well in the
Okay.
past days, and I know something's running.
All right, we should have you call
And I
that
had
phone
I
number.
had surgery already.
Oh, gosh, okay. Well, we can talk then. Yes, ma'am.
Oh, me. So I wanted to know, how common is kidney stones in younger ages? I'm 21. I've had over 10 kidney stones in the past 2 years that I've passed. So I'm just wondering, of varying sizes. Most of them are smaller, but I've had, quite a few, 2 or 3 that are 5 millimeters.
Sure. So that's hard to say, but what I will say is that if you take sort of lifetime incidence of kidney stones, that's growing. It used to be something like 6 to 7% in the 50s and 60s, but now it's really estimated at close to 10% of the population will get a kidney stone in their lifetime in the US. That's not true everywhere. However, the incidence of kidney stones in younger populations is also increasing. And this isn't, an entire another talk, but that changing demographic is also, well, it's probably a lot to do with diet and so on. Because the types of kidney stones and the types of things that we see wrong on that 24-hour urine are starting to resemble what adults have in kids. Whereas it used to be that if you have a kid, or somebody really under 16 with a kidney stone, that they really have something wrong. Like they have a genetic disease, or they have some drug that they're taking, or something is causing the kidney stone rather than just, diet and fluids. But now that's starting to change over. So in your case, I don't know when you started having kidney stones, there could definitely be an underlying issue, but it could also be just something much more, straightforward. But it definitely deserves attention.
Yeah, I've been working on it.
Yeah. Yeah. Yes.
I had a stone removed and they put a stent in, and then I developed sepsis.
Yeah.
How prevalent is that problem?
Very rare is the bottom line. Anytime you put an instrument into the body, you have a risk of infection. If you take all patients who have a ureteroscopy, the estimated risk of urinary infection afterwards is going to be somewhere in that about 5% range. Sepsis is going to be much less than that. But, our thinking on this is evolving. I think infections are probably more common than we like to believe they are. So does it happen? Yes. Is it common? No.
Yeah, my blood pressure got extremely low. I was in hospital for 2 weeks.
Yeah.
I was almost dead. They asked me if I wanted to see my pastor.
The key is to catch it early.
How come they didn't give me antibiotics right after they put the stent in? Just in case.
The common practice, well, again, a lot of thought goes into this, but the vast majority of patients are not going to get an infection. They don't have a history of infections, and they won't get one afterwards. And so all they need is a single dose of antibiotics right before the procedure starts. There are some patients who are a little bit higher risk because they have diabetes, or they have a history of infections, or they have poor immune status, etc. Now they may benefit from having antibiotics to go home with even after the procedure. But that's a very individualized thing. I can't necessarily answer why they didn't do it for you. We can look at your history and figure out whether you should have gotten it or not, or if you needed a procedure for your 7 mm stone, would we do it? Based on your history of sepsis, I would probably give you antibiotics to go home with this time around.
Okay, thank you.
I do want to take a moment to answer some of the questions that are coming in online. And thank you to the attendees who joined online. We had close to 60. So someone asked if you could expand, Dr. Jain, on ultrasonic propulsion and burst wave lithotripsy treatments that don't require sedation.
Right, so a couple of things here. So what they're talking about, burst wave lithotripsy, is a new technology. It is not available for anybody to buy. So, we couldn't go to the company and buy that system and start using it today. It was developed at University of Washington, and it's basically in clinical trials at this point. The thought process is that they have a little microphone-looking thing, and that puts out little bursts of ultrasound waves, and they point it right at the kidney using ultrasound in clinic. And the thought is that if you have a small stone, like if your 7 mm stone was actually 3 mm, and we could see it on ultrasound, what we would do is push it out of the calyx into the kidney, and we actually make you pass it. So that way it's out of, out of the system, as it were. But that's the propulsion. That's the ultrasonic propulsion. The burst wave will break up the stone, and they say that you don't need any sedation or general anesthesia with it. I think, like with any surgical technology, it's going to require more trials and more data to say that does it work as well as shockwave, standard shockwave lithotripsy? That's really going to be the main comparison. And then 2, can you really do it without sedation? I mean, the last time I talked to the person who developed the technology, he was here actually in 2018. We had a stone conference here, which is called the Rock Society Conference on purpose. But he was very excited at that time about the technology. And it's definitely going to have some usage, and it will gain some traction. Whether it's going to replace shockwave lithotripsy in efficacy remains to be seen. But yeah, so I don't have a lot to say about it because there's not a lot out there about it. It has some very small size trials.
And then just to kind of go off of lithotripsies, if your body keeps producing calcium oxide kidney stones, is there a limit to the number of lithotripsies you can have? Could it potentially damage your kidney?
Yeah, that's a good question. So, it makes sense, right? Like if you're sending 2,500 shockwaves through your kidney and you're doing it a few times a year, then it stands to reason that you're probably damaging the kidney. The data doesn't really show that that there is an increase in the risk of chronic kidney disease with the number of shockwave lithotripsies. There's no correlation that's been shown there. Now that is with a big asterisk, as there is with a lot of surgical literature, because the way surgical research is done doesn't often lend itself to sure statements that say, yes, shockwave lithotripsy does not increase your risk of chronic kidney disease. I can't say that definitively. However, the data we have available does not show that to be the case. Having said that, there are some studies which show that the number of shockwave lithotripsies that you have in your lifetime can potentially increase the amount, your blood pressure. So it can increase the risk of hypertension in patients. But that's also counterbalanced by some studies that show that there is no such risk. So the short answer to that is that probably not, but you really probably want to limit the number of lithotripsies you have or number of ureteroscopies or PCNLs you have as much as you possibly can.
Thank you. And then we had several questions about, a person's individual circumstances and their case and what their treatment options would look like. So what do you think the best
Well, it depends on
option is for them
time.
to do?
I know we're a little over time. I'm happy to stay. Do we have any general questions? Yes, ma'am.
So probably 10 years ago, we met with a registered dietitian because between the two of us, we have multiple medical issues, one of which is kidney stones, and we brought the 3 different papers with us and said, please help us figure out a diet where we can manage our lives better. And 2 things, the registered dietitian basically threw up their hands and said, wow, good luck. That was first. And secondly, because neither of us mercifully had diabetes, there was no medical insurance coverage to
Correct.
dealing with the registered dietitian.
Yeah.
So I saw on your slide you had one. So is this person able to do stuff with a more complex
Yeah.
thing? And is it still on my nickel?
Yeah, so a couple of questions there. So we have a pretty deep collaboration with the Center for Community Health and Prevention out of the University of Rochester. So they have a team of registered dietitians, and they have a couple that are more interested in kidney stones, and those are, we send them the referral and they assign it as they see fit. But they've done a pretty good job, I would say, from the reports that I've gotten back and patients that have given feedback and say, well, they really did help me figure out a plan and a meal plan and things like this. In terms, so I think to your first question, yes, I think that they can probably help you with more complex issues. Sometimes there isn't a satisfying answer because there are dietary needs for different medical issues that are that need opposite things, right? So you can have, you can say that, well, yes, you should have a potassium-rich diet for preventing kidney stones, great, but you can't have more potassium if your kidney function is poor, for example. It's just one example. So you may not have a satisfying answer, so you may need to weigh the risks of, well, which thing do I want to optimize? Is it my end-stage kidney disease, or is it my heart disease, or is it my kidney stones? And so first question, yes, they can definitely handle more complex patients. Second answer is that you are correct that coverage for registered dietitian consults is poor in the US. There are a few indications where it's sort of a no-brainer. So diabetes is one of them. Obesity is another one. Kidney stones are sometimes covered, sometimes not, if that's the only indication. So usually, there is a pretty big overlap between obesity and kidney stone formers. So when I'm sending somebody for for a registered dietitian consult, I will put obesity as the indication and then say they also want help with low sodium diet or whatever it is. Which then makes it easy for them to, but they have ways that they can look for other indications that weren't in the original referral to try to get it covered under insurance. But even if it's not covered under insurance, at CCHP, when they do their consult, it's about $29, even if it's completely out of pocket. So for some people, that may be actually better than the copay that they would pay through insurance. So it's not perfect, but it's certainly better than what was available when I was in residency, just a few years ago. So it's getting better. Well, hopefully it shouldn't be that bad. So we can talk about that if you wish. Yeah. Yes, sir.
So you talked about the lemon juice myth. Are there any known foods that dissolve existing stones, or if you have stones, is the only thing just a better diet to prevent them from getting bigger?
Yeah, in general, so about 90% of calcium stones are going to be calcium-based, right? So calcium oxalate, calcium phosphate. They really don't dissolve per se. There are some sort of herbal concoctions from various cultures around the world that say that kidney stones can be dissolved. I think most of them are haven't really been tested in any sort of reproducible way. So I just have to say no. I'd love to know, obviously if you could find that, that would be a gold mine. But with the lemon juice thing, again, there are patients who have told me that, when I have the attack, I do this, and the stone goes away. And it's really hard to know what to make of that without more data, with, imaging and so on and so forth. So
again, if you have stones, the best thing is a better diet so they don't get bigger.
correct. If you already have them, don't let them get bigger. If you don't have them, prevent them from appearing in the first place. Dr. Joseph.
Hi, my name is John Joseph. I have a question. I went through hell over Thanksgiving with a kidney stone.
Oh, gosh.
And I actually hate getting up at night, so I can't drink in the evening. And during the day, I'm in the operating room doing long surgeries. So what do I do? I can't get to the bathroom from the operating room. And at night, I'm trying to get some sleep.
Isn't that why you have residents for the surgeries?
Absolutely not.
That was a joke. We don't do that. That's a hard question, and it's so we have two patient populations that really suffer with this balance, right? Because we have men as they get older, they get enlarged prostates. They often have to get up at night, so they don't want to drink. But then if you don't drink, then you get kidney stones. There's a balance. There's no good answer for this, other than maybe fixing the prostate issue, right? So that's one possible solution if that's the problem. With women, well, not that this doesn't affect men, but it tends to affect women more, is that they have something called overactive bladder, and it becomes more and more common over as your age gets higher, and you get this urge to go even if there is no significant amount of urine there. But if you do put more fluid in there, then that urgency gets worse and it gets more and more frequent. So we have that balance. And again, it's about treating the other side of the coin. It's about treating the overactive bladder. So you need to do pelvic floor physical therapy, or you need to be on medication, or have a procedure done for it. So it's trying to treat the other side of that coin.
So I don't have a prostate problem that I'm aware of, not yet, no prostate problem yet, but it's just the prevention aspect, trying to work on it, and it's just hard. I just want to articulate that, we all experience that as well. Lifestyle does matter. How much you drink matters. I'm sure you made those points, but I'm struggling with it. And as a physician, as a surgeon, it's a problem. And
so one of the things, as I was saying about surgical literature or medical literature in general having a lot of problems, one of the things that we know we have a problem with is following patients over time. And so with kidney stone prevention in particular, some of the few very well-designed observational studies that we have is that people really don't follow behavioral or dietary guidelines beyond. So, the adherence is very high immediately after a kidney stone event or a procedure, and then it slowly drops away. And that's natural, right? Everybody will struggle with that. But the data is there. If you keep following it, you'll do well. So it's hard, though.
I wasn't here to do the introduction. I just wanted to quickly say that thanks to Dr. Jain, we're very fortunate to have a fantastic medical center here in Rochester where we can recruit talents like Dr. Jain, who joined us from the Cleveland Clinic. So round of applause. And I'm sure you share his fantastic insights. One of the most experienced kidney stone doctors in the country. So you have him right here to share his knowledge with you. So we're glad you're here to be part of this. And I gave my example because you're not alone. We are all in it together. And we are in it in many ways, trying to prevent, trying to do the research to advance the field and try to prevent stones, prevent more suffering. So we thank you all for being here. Again, also thanks to Dr. Jain and the team now for putting it all together. We're coming to the end of the hour. I don't mean to close it if you have more, there are more questions here. Perhaps folks want to ask you individual questions, but it's been a fantastic production. The team here doing it all together. We've been here since 7 o'clock this morning with another conference we had for the physicians. And it's a team effort. We have a huge team here, so I'm glad you all came to take part, and I'm sure we learned quite a bit from you as well. So thanks for being here, and congrats to all of you for being here as well. Thanks, Dr. Jain.
Thank you. I think you were next?
I'm going to see you next week, so I
Oh, fair enough. Okay.
We do have a few more questions
Yeah.
online. We have an attendee who lives in Niagara County. Do you know of any physicians that work in that area?
There are some folks out in Buffalo. We can certainly get in touch. We do consults and appointments over Zoom, so just because we see patients from, all the way out in Binghamton and Pennsylvania and, Erie, Pennsylvania, and all over the place. So that doesn't necessarily mean we can't see that person. But it, having an in-town point of contact is also important. So we can certainly find somebody for that patient, yeah.
Thank you. And we have a patient who had a recent CT from U of R showing stones and cysts and has had blood in the urine and diabetes, BPH. Do we need a referral from a GP or urologist?
That depends on your insurance. We do not require it ourselves, but if your insurance requires a referral, all that means is usually just sending a message to the GP to put the referral in, but we don't necessarily require it.
Okay. And is there a connection between sarcoidosis and kidney stones?
There can be. So sarcoidosis can cause a series of sort of downstream changes in the body physiology, which can cause more vitamin D and more PTH and more calcium to be extracted from the bones and dumped into the urine and cause more kidney stones, yes. So can be, yes.
All right. And does anyone in the room have any more questions?
Yes, sir.
How long would you normally wait before you seek? How long would you normally wait before you seek like surgical options?
If you have a stone that you were seen in the emergency room and you were sent home to try to pass it, in general, it would be about 4 to 6 weeks before you would say that trying to pass it has failed, and then you want to treat it really ideally before 2 months. If the kidney is obstructed, some of our data shows that beyond that 6 to 8 week time frame, you start to get some irreparable damage to the kidney function. So having said that, I had a patient who was a pro at passing kidney stones. He had an 8 millimeter stone, and it had been already 2 months. And I said, look, I told him all of the stuff I just told you, and he said, look, I'm going to pass it. I'll let you know. And then sure enough, 2.5 months later, I got a message from him that he'd passed his stone. So, some people just know that, but ideally, you'd never want to become such an expert on your own kidney stones.
What about pain? Did the pain come back and forth?
Oh,
more?
sure. Yeah, absolutely. So one of the downsides of sending somebody home from the ER once their pain is under control is that they may be right back the next day or back the next week. And, usually then if somebody is in the ER for a second time, we may try to offer them a procedure at that time. That's not always possible because, like I said, kidney stone incidence is increasing, so we're busier than ever, but we try.
one reason or another to do an image, thank you, with an X-ray or with a CAT scan or with an ultrasound?
Yeah, absolutely. So depending on if you have a known type of kidney stone, it may not show up on an X-ray. Uric acid stones, certain other types of stones don't show up on plain X-rays. So there's no point, if you know that's the type of stone you make, there's no point in getting that type of imaging. And so you would have to get one of the other ones. Now, the other thing is that, kidney stone formers tend to have recurrent kidney stones, so they get a lot of imaging over their lifetime. And especially if you have had a lot of CTs done, then you want to avoid doing CTs unnecessarily because it's more and more radiation. So you want to do it selectively. So we don't always have that ideal CT image, because that gives you that confidence that you know exactly what the stone is, where it is, how dense it is, how big it is, how many there are, that you haven't missed anything. But we sometimes forego that surety to avoid excess radiation, or so we get by with less data maybe with an ultrasound. But sometimes that's all you need.
Do you have time for a couple more questions?
Yeah.
Okay. So we have an attendee who said, I have a CT confirmed 1 centimeter by 1.7 centimeter stone on my left kidney only. Will this require invasive remediation, or will stone crushing be an option?
If by stone crushing you mean a shockwave lithotripsy, then that isn't a great option for that size of stone. In general, I have had one patient who swore that their 15 millimeter stone was going to break up if we did a shockwave lithotripsy. I said, it's not going to work. She said, it's going to work, just do it. We did it and it worked. So I don't know. She had it done once before and it worked well, and it worked well the second time. Having said that, the data is not with this patient in terms of getting a shockwave lithotripsy. The likelihood is that it would break up a little bit and not enough to render her stone free, and probably would require more than 1 or maybe even 2 procedures. Realistically, she should probably have a ureteroscopy, and she may need 2 of those depending on the density of the stone. If she wanted to have the best chance of having a single procedure, that would be through a PCNL or through the back, which is invasive, but it's fairly minimally invasive.
How is the type of stone identified?
So when we take a piece of the stone, we send it to a lab. I think currently the lab we send it to is based in Florida for some reason, but there's a bunch of them all around the country. But they do a type of analysis which is called Fourier transform infrared spectroscopy. But basically that's just finds the different components and tells us the percentage of each component in the stone.
Is there any advantage to drinking alkaline water?
Actually, possibly. So, naturally carbonated water, like spring water, which is naturally a little bit alkaline, may be helpful. Yes.
Thank you. Well, thank you, Dr. Jain, so much for staying late, answering all of our questions. And I just want to echo Dr. Joseph's comments on you. You're really, you may not be aware outside of being a clinician, Dr. Jain he's continuously researching and trying to find evidence-based treatments to further help his patients. And if you do have any questions after the seminar, please feel free to call our office, 585-275-2838. We will work on disseminating the presentation materials to you all afterwards.
Thank you very much.
Thank you.